Welcome everyone to the September 15th, 2020 COVID-19 clinical rounds on critical care. Today's critical care presentation will be a case presentation. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 critical care challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are the clinicians with the most experience. This is a voluntary public-private collaboration, thanks to the multiple professional organizations who have collaborated. These are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC has webinars that complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming Project ECHO COVID-19 clinical rounds currently are all US noon Eastern time. This Thursday, September 17th, will be at emergency department rounds, and we'll have a case presentation for those rounds. Next week, we'll have our usual schedule. Monday's EMS rounds will be focusing on proning in EMS and critical care transport. That particular session is a result of the numerous comments and chat that we saw during the critical care rounds case presentation on proning. Tuesday's critical care rounds will be critical care pediatric case presentation. Thursday's emergency department rounds will be an emergency medicine resident's perspective on patient care and clinical operations. Stay tuned for announcements for future rounds. We'll continue to work to identify topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. These clinical rounds have included participants from over 100 countries and all United States states. We apologize, we're not able to answer all the questions we receive. We do pick out major themes from and hope to cover some of those. Dr. Bruce Struminger will now go over some logistics.
Thank you, Rick, and welcome everyone, and in particular, special welcome to the Nebraska team that's going to be presenting today, and as usual, to our guest expert panelists and to the over 125 participants who signed in already. Just to go over a couple of logistic items. Hopefully, are you seeing my slides, Rick?
Yeah, they're not quite in presentation mode, but we're close.
Yeah. Okay, sorry, let me try that again. Great, so just a couple of housekeeping logistic items as usual to review. We love your questions and comments, so keep them coming. Please put them in the Q&A space by pressing on that Q&A function button at the bottom of the Zoom toolbar at the bottom of the screen. We'll do our best to track those and hopefully answer some of them or as many as we can. Also, if you have any technical or logistic issues, go ahead and mention those in the chat. And Rick has a crowdsourcing question he's going to ask in 2 or 3 minutes, and the chat function is the best place to put your reply. The session is being recorded and your attendance is consent to be recorded. Thank you for that. The recording will be made available in 2 or 3 days on our website, and we'll put a link to that website in the chat as well. There's a whole archive of all the recordings from the last 6+ months and all the PowerPoint presentations So you can find them all there. Today's PowerPoint presentation that the Nebraska team will be sharing was also made available through a link in the announcement that went out this morning, and it will be up on our website as well. CME and continuing professional development credit will be available through the University of New Mexico, where Project Echo is based. About 15 minutes before the end of today's session, we'll put a link in the chat. There's a brief survey, and you will then be able to get an instant CME certificate after completing the survey. We really value your feedback and comments. So even if you don't care a lot about the CME or CPD, we really encourage you to fill out the survey and give us feedback so we can continue to improve these clinical rounds. These learning sessions are focused on improving patient care and health systems and supporting clinicians. Just a reminder, we want to keep this apolitical and non-commercial, so we thank you for that. Just a note about data use. You share a variety of data with us when you register, during the polling, in the chat, in the Q&A. Most of it's de-identified, some of it is identified. We just want to ensure everyone that we take data stewardship very seriously, and we really do a very careful job of taking care of your data. We do share de-identified data with Rick and Asper so that they can use your input to help guide the COVID-19 national response. With that, I'm going to pass the microphone over to Dr. Bruce Ribner at Emory and NETEC. Bruce?
Thank you, Bruce. And good morning or good afternoon, depending on what time zone you're in. I'm Dr. Bruce Ribner from Emory University and principal investigator from Emory for the National Emerging Special Pathogen Training and Education Center. Our website is netec.org. And at that website, you will find a great many resources, both COVID and no COVID related. With regard to what Dr. Hunt was mentioning earlier, we are running a series of webinars which are complementary to the webinars which are being run by Asper on this ECHO series. This Friday, we have one on palliative care and COVID-19, and we'll be having subsequent ones on personal protective equipment and on pediatrics. So if you go to netec.org and click on the education button, you will find a whole agenda of our webinars, which are scheduled, and registration information. Thank you.
Great. Thank you, Bruce. And now I'd like to pass the mic to Dr. Rosha McCoy with the AAMC to give us an update on the COVID-19 clinical guidance repository. Rosha.
Thank you, Bruce. Yes, we're just continuing to remind everyone of this resource. We're continuing to update with guidance as it comes along. We're hoping to get some new guidance on influenza and COVID. We're looking for that at this point, but right now we're just updating with the most recent guidance. So I'll put the link in the chat box as well, but you'll see the website address on top. We hope this is helpful to folks.
Great, thank you, Rosha. And Rick, back to you for the crowdsourcing question for today.
Yeah, people are going to see the crowdsourcing question, but before I actually ask that, I just want to particularly give a vote of appreciation for NETEC's doing the rounds, upcoming rounds on PPE compliance and fatigue. We have spent a lot of time on these rounds over the past couple months talking about mental health, fatigue, and complacency, and to see a focused effort trying to fight that in a way that makes it so we don't let down our guards. We'll probably save some lives. So really encourage you to participate on that one. I'm definitely going to try to. So the crowdsource question, it's critical care rounds, and so we haven't gotten around, we haven't talked about labs in quite some time, actually, early on in the response we did. So it seemed appropriate to see where we might be with the use of labs in critically ill patients. So the question for today is, what is the most helpful lab you ordered to support the management of critically ill COVID patients and why? So once more, what is the most helpful lab you ordered to support management of critically ill COVID patients and why? Thanks, and if you could jump on that one, just like you do when we do the polling, that'd be great. Would be really helpful to see your responses. So let's see, I'm trying to get to the screen to see who's on. If those who are participating as panelists could please go ahead and unmute yourselves, that would be great. And if each of you could please introduce yourself with name, title, and affiliation. Bruce, I think we've got you with NETEC. Carol?
Good morning. I'm an emergency physician. I am the State Medical Director for the Ohio Department of Public Safety Division EMS.
Thank you. And I see an Erica. I wonder if you might introduce yourself?
Hi, I'm Erica Shinoy. I'm not part of the panel. I'm just a participant.
Great to have you on. Welcome and glad you joined. All right, so with that, I'm going to go ahead and introduce our speakers. And it's actually really gratifying to have some critical care nurses present on these rounds. We have a large number of participants who are nursing, and us docs need to learn from you. So with that, I'd like to introduce our speakers, Andrew Gomez and Jen Kopp. They are staff nurses on the cardiovascular ICU and biocontainment COVID ICU at Nebraska Medical Center. So please, Andrew and Jen, welcome, and I'm going to turn it over to you.
Awesome. Thank you, Dr. Hunt.
Thank you.
We just wanted to give a presentation about our very first experience with placing a COVID-19 patient on ECLS. So if you want to share our slides up there, we can get started. Other one. There you go. The bottom right. So like we said, just a case study presentation and some of our wins and opportunities for improvement that we learned about during this period of time. We are sharing a keyboard here while we dual present, so we are working through this together. So just a brief explanation for those who aren't familiar. We are talking about extracorporeal life support, ECLS, or you'll also hear it called ECMO, which is extracorporeal membrane oxygenation. Sometimes those terms are used interchangeably, but essentially it's a device that functions similarly to the cardiopulmonary bypass machine that we use during heart and lung surgeries and other procedures as well. But it circulates and oxygenates a patient's blood outside of their body, which decreases the metabolic demand of their heart and lungs and allows your patient's body time to rest so it can heal while still providing oxygenation and ventilatory support. It's important to note that ECMO is not a curative therapy. You still need to have patients that have an exit strategy off of it. It just gives the body time to heal while we are still supporting their organ function. So this is just a schematic of one possible veno-venous ECMO cannulation strategy for patients where it's pulling blood through a multi-stage catheter in the IVC, oxygenating it, pulling it through a centrifugal pump, oxygenating it, taking CO2 off, and replacing the blood back in through the right atrium to circulate through the heart. So it is important to note that your patient still has to have strong cardiac function for this therapy to be effective and safe. So in the context of COVID-19 induced ARDS, we were utilizing veno-venous ECMO, which is lung support. It provides for us to be able to titrate the amount of oxygen and CO2 that we are replacing and removing from a patient's blood, which allows us to utilize protective ventilation on these patients. We know that in ARDS, it's really important to protect your patient's lung tissue. So we are able to use smaller tidal volumes, lower PEEP requirements, so these patients can heal and have an opportunity for improvement. This is a therapy that, barring complications, we can use for days to weeks, so your patients can heal from ARDS. One of the most important, in my opinion, considerations for ECMO is candidate selection. So as I mentioned, it's important for these patients to be able to have the reserve to heal, and candidate selection is so important. There are relative and absolute contraindications for these patients to be placed on this type of therapy, including other comorbidities, their body habitus to allow for safe cannulation, ability to tolerate anticoagulation if that would be necessary. And then we also have to talk about extrinsic factors, like do we have the nursing staff and the medical staff to safely care for these patients, and other sorts of resource constraints.
So here's more of the case study presentation and some patient background. History of present illness for our patient. He was a 32-year-old male with no real medical history prior to this. Some possible undiagnosed type 2 diabetes. He did get a COVID positive diagnosis 4 days before admission on April 10th. He did not have a COVID known exposure, however, was working with high-risk populations. He presented to our ED on the 14th of April and was in respiratory failure. He was statting approximately 60% on a non-rebreather, was only mildly symptomatic, and was still able to ambulate around in the room. He proceeded to quickly decompensate from there. We intubated him and transferred up to our COVID ICU that we had stood up specifically for this. And then we immediately used proning and paralytic therapy to promote ventilator compliance. So brief hospital course for him. He was intubated for a total of 21 days. Throughout that, some of the things that we ran into were high levels of PEEP, up to 20 for him. We had airway pressure issues, and then just quite a bit of difficulty managing our paralytic therapy and sedation just to promote compliance for him. We ended up consulting our cardiothoracic surgery and our critical care anesthesia team for his ECMO candidacy, since they're our primary teams for that here in the hospital. His total ECLS run was about 17 days. And after that, during that time, we did elect to go ahead with the tracheostomy, which he had for a total of 27 days. And we did go ahead and do the tracheostomy while he was on ECMO, just to provide that safety net for us in case we were to run into some more airway or ventilatory issues. His total ICU stay was 41 days and total hospital stay was 47. So some of the basic complications that we ran into, he did suffer a ventilator-associated event. He had secondary pneumonia to Klebsiella. He did develop a CAUTI, catheter-associated UTI, due to multiple Foley's placed, including one of them being a large bore Foley for some urinary tract bleeding. He developed several pressure injuries on his lip, right heel, coccyx, part of which was from the proning therapy beforehand. He developed a pneumomediastinum. Not sure whether that was related to the high PEEP and airway pressure issues that we had, or if it was a possible COVID-19 complication. And then one of the biggest things we dealt with later on in his care was our opioid versus benzo withdrawal. During that time, he was on high amounts of sedation and various agents from there that we had issues weaning as time went on. So for us, some of the big care wins that we had, probably one of the best ones we had was our biocontainment leadership had the foresight to start recruiting ECMO-trained cardiovascular ICU nurses as early as 2018 to prepare for this possible respiratory pathogen outbreak. Some of our core biocontainment staff were able to be peer-to-peer mentors, such as Jen and myself, to assist CV nurses that were not on biocontainment with getting used to the procedures of the unit and how things were run up there, since we were away from kind of our home unit. And then we were able to actually create a list of experienced CV nurses to volunteer up on the COVID ICU to help us staff and provide care for these patients. We also kind of created a ECLS crash course for leads up on the COVID ICU that were not familiar or trained on ECMO, which really helped them understand what to do, like a basic idea of what to do during specific situations, and to help get the appropriate resources and staff there to respond. And one of the things that we really did experience was nurse burnout and fatigue, just due to the increased PPE requirements. just the stress of the pandemic and the changes in staffing and policy and procedure as the pandemic progressed. So we actually developed peer support and therapy by our behavioral health department. Some of the innovations we made during this time, we utilized iPads up on the unit to maintain video monitoring of our cardio help system, and it also helped with our communication with our providers in and outside of the room to reduce foot traffic. We created a ECLS crash box, essentially, that we kept at the bedside of our ECLS patients up there that contained fluids, 1 to 10 epinephrine sticks, neosynephrine sticks, and various tubings as well. So our nurses could essentially react and stabilize the patient appropriately until we could get all of the staff there at the bedside as well. And then we also improved our process of communication and line of command. We created a formalized handoff between nursing and physicians. So we knew who was on call, who were our ECMO specialists at the time, who was available, and who will be providing care for that patient overnight. And then we also utilize our ECMO specialist checks Q4 from the iPad to reduce foot traffic as well.
Some of the opportunities for improvement that we identified, one of the bigger ones was the continuity of care with these patients. So initially on our COVID ICU, it was a critical care medicine team managing the care of these patients who are Pulm Crit Care trained, which is fantastic for COVID-19. But when we had ECMO added into the mix, we feel that right off the bat, if we had our ECMO trained physicians, so our critical care anesthesia team here at our facility, serving as the primary team to fully manage the care of these patients on all shifts, rather than being a consult team, would have been beneficial, even though it is something that we intervened on and that was eventually what was decided upon. But just an early delineation to all of our staff on what attending team is running the show, since these patients are so complex and critically ill. And ECMO plays a part in all of those things rather than just having an ECMO consult team. We did have some restrictions just being on an isolation unit as well. It was really difficult to rehabilitate this and all of our patients. Typically, we would want these patients up and walking the halls and doing what we can to rehab their pulmonary function so we can get them off of the circuit, off of the ventilator, and improve their outcome quality as well. So we are also geographically distant from our home unit where these ECMO patients are typically located. We think it would have been beneficial to have all of our ECMO patients on one unit, because during this time we still had patients on the cardiac ICU that were on ECMO circuits as well for other indications. So obviously in facilities, there's going to be limitations for negative pressure rooms, and it would be implemented where safe and appropriate, but that was another one of our recommendations. And then just the early implementation and preparation of our ancillary services, such as physical therapy, occupational therapy, and our other ancillary staff. But it is also important to remember that at this time we were limited on PPE, and we still weren't sure, as far as ancillary staff, who we were going to allow in the room, what was appropriate, and things like that. Another important point for our ECLS and all critically ill patients is our patient advocacy from a nursing standpoint. We just want to highlight goal promotion and clarification for ECMO consideration for these patients. As nursing staff who is ECMO trained, it's important for us to advocate for these patients to consult our CT surgeons and consult our ECMO trained physicians if we feel that this patient is a candidate, and to be another factor in promoting the early cannulation of these patients, since there's a vast amount of literature that suggests that cannulating these patients earlier rather than later is associated with better outcomes. And then also just care management issues such as fluid balance goals for your patients. We know that we want somebody to not be fluid overloaded so their lungs can heal, but it's also necessary to have a patient be euvolemic to provide flow in the ECMO circuit. So just managing those goals. And then minimizing sedation and paralytic therapy, just working towards getting your patient off of their drips and off of their ventilator and circuit and getting them essentially with the goal of being out of the hospital, and clarifying goals for ventilator settings and PRN order needs, and then clarifying with our physician teams what our plan is if an emergency happens or if our patient starts decompensating, because at this time it was just one nurse at a time in the room. And if you needed a physician, it took time for them to get PPE on and be safe to come help us. So having those plans in place so we can start intervening appropriately if an emergency were to happen.
So some of our lessons learned were just the incredible need for teamwork and continuity of nursing care and providers. We really stress the significance of having the one-to-one nursing care for these critically ill patients especially. And some of the other things we learned was just the way we formatted our rounds to address the needs and concerns, kind of like Jen had mentioned, like how are we going to prioritize these what if situations and who is going to be available and when we can get them there. The shift handoff and sign out formatting for nursing and medical staff basically created this nice long flow sheet of who was there, who was available, and numbers and things like that. And utilizing the Zoom meetings for family education updates really helped provide a lot of that additional care for our families and patients, and just keeping them involved and able for them to see their families and loved ones. And we did innovate with our circuit checks and involved bedside nurses and rounds when able to leave the room just to conserve our PPE. It really helped just branch out for our communication as well.
This is just an excerpt of an email from Dr. Jim Sullivan. He is one of our critical care anesthesia physicians. He's also a core staff physician for our biocontainment unit here at Nebraska Medicine. He sent us this wonderful email to staff when this patient was discharged from the ICU. And if you read in there, he said he couldn't even hallucinate a reason to keep him in progressive care or the intensive care unit. So this patient, despite us it being a learning process, getting an ECMO patient on a completely different unit in the hospital for the first time during a pandemic with tons of extra PPE, we were able to promote a really positive outcome for this patient. So this was somebody who, when he came into the emergency department, we weren't sure if he was going to survive, let alone have such a significant quality of life when he recovered. So he sent us this email just kind of highlighting the teamwork that it took to get us through this point. So this is just some fun pictures of us in our PPE and communicating through the window of a negative pressure room that one of our nurse colleagues sent us. A lot of the times we found ourselves waving our arms in the air and directing traffic like we were trying to land a 747 in the room to communicate needs and issues. And we actually became really good at this. And we noticed that we started doing it on our home units when it wasn't necessary, which we thought was kind of funny. We have our quarantine shirts, and on the top right is Andrew in our PPE set up on our COVID ICU. These are just some of our citations. And then we would like to give an opportunity for anybody to ask any questions or make comments. And I guess we could stop screen sharing probably.
Andrew and Jen, thanks very much. 41 days in the unit. I don't know what the mortality rate is on patients for 41 days, but it sure probably isn't really good. So congratulations. I mean, it's a Herculean effort. I've got one particular question, and then I'm going to turn it over to Bruce and Carol for any of their questions or comments. So I, as I heard this play out with the Klebsiella, the UTIs, the pressure injuries, the pneumomediastinum, I'm betting on Pete, but what the heck, and opioid, the opioid challenges and the weaning and so forth. One of the things that we've talked about quite a bit and actually had one of our rounds focused on transitions of care from critical care to wherever. And this one, it was fascinating to see, went from, the ICU, ECMO to the floor. How about, okay, then what? Are you aware of whether or not he ultimately got discharged to home, how he's doing now? Did he get to go to long-term care? What his needs are at this juncture?
So that's a fantastic question. And we did receive a media release from this patient, obviously. But he was able to transfer from the hospital to home. He did not have any need for a rehab facility post-discharge, which was really incredible. He was a young man, but he experienced so much while he was here in the hospital. So his possibility for having debilitating issues when he left were very high. but he was able to go home, gave tons of interviews on our local news networks and lots of news articles and everything, and just his commentary on things. And the fact that he is home and I believe working now, I'm not sure if he is or not, but I feel that that's what I had read about him at this point. So I think that that was really phenomenal.
Yeah, I'm thinking his age had a lot to do with it. 32. I mean, yeah. Wow. Bruce or Carol, Carol, and then over to Bruce. Carol.
I had two questions. COVID is associated with a hypercoagulable state. And I was wondering if you had any challenges with that, with your ECMO patients versus patients who are non-COVID. And then my second question is, you mentioned that it would be more ideal to have specialized teams. And I agree with that. We learned that with Ebola. You can't train everybody to a certain level, and it's better to have, very specialized teams that do it every day. Nebraska, I understand, was not one of the heavy hit areas, but New York City was. I was wondering if your team or your hospital either had established or has established some type of matrix where if there are more patients that need COVID or who need ECMO for COVID, how you would delineate which patients would get that resource, age, comorbidities, et cetera, or even if you've had those difficult discussions.
I know prior to planning for this, and as they started recruiting cardiovascular ICU and ECMO trained nurses, that was one of the things that they spent hours on. I'm not entirely sure on every exact indication or what would actually rule somebody into receiving that therapy, but I know that was a huge topic of debate on which patients would be appropriate and which would not, and we tried to stick to those guidelines as best we could but also offering it to the patients that needed it the most.
I think one of the biggest things to highlight with it as well is just the candidate selection and the fact that even if, the really unfortunate part about it is that even if you have somebody that might be a good ECMO candidate, if we don't have the circuit available, if we don't have the perfusion staff, the anesthesia staff, the surgery staff, the nursing staff to take care of these patients, it's not ethical or safe, in my opinion. It's not ethical, and it's definitely not safe to have these patients placed on a therapy that can't be adequately managed. So it's, again, you have to have the staff. Just having the devices available isn't enough. We have to have the staff that's trained to safely take care of these patients so they do have good outcomes, because the last thing that we want to do is put somebody on this complex high risk therapy and hurt them more than we help them, which is, we try to avoid that everywhere in medicine, but it's really highlighted in ECMO therapy and in our practice as well. To answer your hypercoagulable state question, that was one of these patients are really unique and every single one of them is very different. One of the complications, so he had a catheter associated UTI. He had urinary catheters that were replaced constantly that we decided were indicated because his fluid balance was so important. And he was having urinary tract bleeding and he was actually clotting off his Foleys all the time. We had to send him down for ACT at one point, and he was retaining urine in his bladder, but still having urine pass out of his Foley at like 150 to 200 cc's an hour. But he was bleeding in his urinary tract. So that was strange. And also, like, we had to get urology involved and do all of that as well. So I had never seen a patient do that before. I don't know if you have, but
No, it was really strange.
yeah, it was strange. With the ECMO circuit, however, we did systemically anticoagulate him with I don't remember if we used heparin or bivalve.
We started heparin.
Yeah, we switched to bivalve eventually. We had him systemically anticoagulated on bivalirudin and just went to like a PTT goal for him just to keep the circuit from clotting, because we knew that he was going to be on it for quite some time and we wanted to avoid any oxygenator exchanges or anything, because I think that could have been fatal for him.
Okay, thank you.
Thanks. Bruce, did you have a question or comment?
I had a comment, Rick.
Yeah.
Thank you firstly to you two for an excellent presentation. I'd like to point out something that we heard here, which I think the biocontainment units around the country have been very instrumental in assisting in the promulgation of, namely a much more horizontal teamwork approach in these ICUs of critically ill patients with serious communicable pathogens than has traditionally been the case. I think most of us on this call are aware that in many ICUs, traditionally, it was a very vertical hierarchy where the attendings would make the decisions and the nurses would follow. But I know one of the things that we have really learned over the last 6 years in the biocontainment units is how having a much more horizontal approach and having the very active buy-in by our nursing personnel and the other staff really benefits the patients. And I heard that here, and I'm sure that that has helped a great deal in improving the outcome of your patients.
I absolutely agree with you. I appreciate your comment as well. I think that one of the biggest factors promoting the positive outcome of these patients is that I can brag on our cardiovascular ICU, but I think it rings true for our intensive care units across the hospital. We are really, really close with our provider teams, and it definitely is, it is horizontal decision making. We really respect the expertise and clinical input of our providers, but they also are cognizant of how it's always asked during rounds of nurses, well, what do you think we should do? What do you think would work? And just having those conversations, and it really is a two-way street to get these patients better. And I think that the more you involve multidisciplinary teams, not just physicians and nursing, but your ancillary teams as well, into the care of these patients, that you're going to see better outcomes, because we all bring a certain level of expertise to the table. And to bring that together in a teamwork fashion just helps these patients get better faster, improves our outcomes, and helps us help more people.
Yeah, Bruce, I appreciate you bringing it up and the responses there. It actually gives a whole new perspective on the concept of teamwork. This, yeah, certainly brings out that need in a profound way. There are a lot of questions. I won't be able to get to all of them, but have you been proning patients on ECMO?
So far, not at this time. That's not an intervention that we've utilized yet. We've currently done ECLS for 3 of our patients. I know it's been talked about if we were to need it, or versus adding another cannula on our circuit, but we have not actually done that at this time.
There was a discussion with this particular patient that we presented the case study on. We were having a really difficult time getting his lungs to recover, and he had a long ECMO run, and the longer that somebody is on ECMO, the more likely we are to run into complications. We had a long conversation. This was also a very big provider and nursing discussion that we had, is do we need to prone this patient? I know that other facilities, they'll prone patients that are on VA ECMO, that are centrally cannulated. We don't have experience with that currently at our facility. We talked about the possibility of doing it, but ultimately we decided that the risk of proning him was not worth the benefit of doing so, since he was so far out in his ARDS diagnosis that the likelihood of it improving his outcome was not, it wasn't likely. So we opted to not do that, just for the safety risks.
Thanks very much. There's one more question I have, and then one of our participants, Dr. Guardino, we brought him in to be able to ask his questions. So I have one more question, and I'm going to turn it over to Jim to ask his. Well, 2. One is, if one of you could, the crash box that you have, that strikes me as like one of those things that hopefully gets promulgated way beyond your institution. Hope you do something with that. That's a comment, but the question is, and a background on it, one of the things that has popped up in rounds is how one of the ways that the staffing shortages have been addressed is training staff to do things that they didn't do in their previous scope of care. And it strikes me that you've done some of that too. Beyond ECMO, other kinds of trainings that you're doing for staff that you hadn't done before COVID, that can, I'm trying to get a sense of what are the skill sets that are really important for the critically ill COVID patients that, you know, you can take staff and train them up for that particular function?
That's a fantastic question. So one of the innovations that we had here at Nebraska Medicine was to have nurse extenders. So we had a nursing staff shortage because essentially we opened up 3 to 4 new units in our hospital with the same amount of nursing staff that we were utilizing previously without those units. So we were stretching our nursing staff, which isn't ideal, but it was our reality. So we had trained nurse extenders. So these were typically nurses from procedural areas and outpatient areas who had opted to, instead of utilizing furlough and those kind of things, they opted to be trained in the inpatient area. So how I would describe it most concisely would be to wherever a nurse was trained in a level of care, whether it was outpatient care, they were trained to acute care. And if you had an acute care nurse that was a nurse extender, they were trained to progressive care. And if you had progressive care level nurses, they were trained to intensive care types of skills. We actually had an orientation binder and kind of a flow sheet and algorithm on how to train these nurses. So for example, on the COVID ICU, we were training lots of nurses that were acute and progressive care nurses to how do you titrate drips? How do you manage like basics on ventilators? Just how to prone patients, like things to remember when your patient is paralyzed, things like that. And we were signing off nurses saying, yes, this nurse is competent to help with these things. So we were still serving as the primary nurses for these patients, but they were doing some of our tasking for us, like passing medications, turning our patients, addressing ventilator alarms, and keeping patients stabilized until we could get in the room and mitigate whatever the situation was.
I think also personally for me, one of the other big things that skill set wise, like, yeah, it's in our scope of practice, but something we don't practice regularly was actually proning patients. We ended up developing a very like systematic proning protocol. The protocol, if you will. And basically it really helped nurses that were never comfortable or had never done it. We also included our PT and OT and respiratory therapists and got them comfortable with the procedure as well, and had it highlighted throughout the unit. So everybody was kind of on the same page that this is how we did it. And it allowed us to all get more comfortable, and we increased our speed and efficiency at it with much less complications very quickly with that.
We're really good at flipping patients now.
Yeah.
We're very efficient at it.
Yeah, you know, believe me, the proning has been a topic ever since, actually, Bruce, you and I had a conversation about this just when the virus emerged, I think probably back in early March, about proning, and wow, how it's taken off. I'll be really intrigued to see the discussion on proning in EMS on Monday. So your points about the training piece, and sort of like you took a level and then sort of advanced them one level. I think many who have done thinking about the medical response to disasters have long thought that there would be a need at some point in time for flexibility with our rigid scopes of care. And I think this one highlighted it in a dramatic way. And I think more that we can talk about that and make sure that's like put in history books so people realize that that adaptability really needs to come to fruition very, very quickly is really important. So I'm going to turn this over, the plan for the rest of our hour or a few minutes over potentially. I'm going to turn this over to Jim. Welcome, Jim, and ask his questions to Andrew and Jen, and then over to Bruce and Carol for any brief last comments, and then Andrew and Jen, back to you for final comments. Jim, please.
Thank you, Rich. My name is Dr. Jim Giardino. I'm not a critical care doctor. I'm affiliated with the OHSU PSU School of Public Health here in Oregon. And thank you to the guests and speakers. Very engaging, and it's great to hear from our nursing colleagues who are critical to our teams. My questions are more about kind of self-care. I really appreciate what you're talking about the surge capacity for nursing that you guys implement. That's terrific. So self-care is one of the questions. How are you kind of keeping balance with your staff? And the other question has to do with what practices, these sessions have all been about lessons learned as things have evolved. So I would appreciate hearing more about lessons learned about treatment and practices. What has changed in nursing from your perspective, informed by the evidence and observations that you've made? Are there some major things that have changed in how your teams are caring for these patients? And thank you so much.
Thank you, Dr. Giardino. Do you want to go first?
I think as personally for the self-care, that became a really critical piece for us up there. And just with our surge capacity in our hospital, developing these like micro team matrices on how we're going to staff patient ratios and things like that, and adding in the extenders. One of the big things was be able to create a like cohesive and comfortable working relationship. We had people that we've never met, and now we're providing care for these patients. And we eventually moved to providing stable extenders per unit, which actually led to a ton of hiring increases in the ICU. In our ICU alone, we hired 5 or 6 of our nursing extenders. They had been with our unit for 3 months. They had developed a working relationship, and it actually has led to lots of staff increases in staffing in much of the ICUs from there. So that was one really big bonus for that. As far as the self-care, kind of like I know we only had one bullet point on it, but the behavioral health department here at Nebraska Med, and one of the doctors that works with the biocontainment on staff resiliency and things like that was readily available on the unit. It would come by during lunch hours to check on staff, see how we're doing, things like that. And they also provided weekly sessions, not just with like staff, where we could just get together and communicate and talk and kind of hang out and have peer-to-peer support that way. But we also implemented mental health, that's the word I'm looking for, counseling, if our staff would need it. That was readily available via Zoom call and things like that. And I know lots of staff utilize that to just talk about what's going on, not just at work with the pandemic, but at home as well.
I think informally as well, we worked really hard to take care of each other as well. I think that we were good about asking each other the hard questions, having those hard conversations. I know that there were groups of us that would do like Zoom family dinner nights where, you know, we all work together and we're all really tight and we're friends outside of work as well. But instead of getting together like we typically would, we would all order our own takeout and sit on Zoom for a few hours and just hang out, you know, like we typically would pre-pandemic, but not over Zoom. So it was just important to not only utilize those formal resources, which were so immensely helpful, but to also just be cognizant of it on an interpersonal level as well, that we're all going through this together and we're going to come out of the other side of this stronger and better clinicians as well.
And if you look at our unit, we, especially in the early days, we had posters all over our break room of different self-care ideas, and everybody would get to write whatever they were thinking and different topics on each piece of paper. So that was always really fun to see. And it was kind of the camaraderie of being all in it together and kind of banding together in this new environment for all of us.
Which was all completely work appropriate all the time, because we're very politically correct ICU nurses that are always completely professional as well. So.
Any comments about practice changes?
I think that there were lots of different innovative things. There were small things like utilizing different devices in different ways that now we use outside of the COVID ICU, like utilizing Foley anchor stickers to hang on to lines onto a bed while you prone a patient, or now we can use them other ways. And I see people doing it in other ICUs outside of a COVID setting. And just being innovative about utilizing the tools that you have to see them in different ways. But also on a big practice perspective, I think like staffing especially was a huge deal. Being someone who works as, and Andrew as well, being someone who works as both a team lead who organizes staffing for a unit and also a staff nurse and knowing what the other side of that looks like. Being able to be innovative about how we can staff with extenders and still being cognizant of not burning your staff out and doing your best to work with what you have to have not only safe patient outcomes, but keep your staff in good morale and being able to practice well also.
The other big,
Thanks
I guess,
very
really,
much.
now that I think about it, the only other practice changes we had were how we minimize foot traffic in the room, but also maintaining medication patient safety and things like that. We changed our dual RN sign-off processes, and to prevent nurses going into the room together, we created a special thing with pharmacy and our Medicaid, like our MAR and our EHR, how we do dual RN, meeting all the requirements for that, right patient, medication, and so on. Outside the room, we changed our dual RN sign-offs for our like vent, probe, dilaudid, things like that, which I think really streamlined and reduced foot traffic in our room. So that was probably the biggest change. And we actually have developed that and adopted that throughout the hospital as well, not just in our COVID ICUs.
Jim, thanks very much for like getting pulled in. Seriously, this is going back to like the beginning of rounds. You know, Bruce said, you know, we can pull people in and to ask questions, participants in. And thanks for being one of our very first. You might have been the first that we've actually been able to do that for, and really appreciate that. And also, it's great to see your face. And for participants who are still able to be on, even though it's getting close to 1, we want to do that in the future too. So don't be shy. Ask a question, and we'll see if we can pull you in. It's not hard to do, as you just saw. Let's go to the polls if we could. There's 5 questions. These are not like, you know, we had the workforce ones of like 10 options for each question. These are a whole lot more straightforward. Well, I think they are. They surely aren't as long. Okay, so, you know, we've done, as Dr. Ribner has reminded us, like we've been doing this for 6 months now. So in September, like this month, which of the following is the most difficult to manage in critically ill COVID-19 patients? You know, I kept looking, what am I missing here? What am I missing? So somebody like shout out and like in the chat if I missed one of the options, but I tried to like cover the system as best I could. And what I've heard on the rounds, more important. Well, you know what, now, come on, group, only got 22% of you voted. We do better than this now. You know, Andrew and Jen, maybe it's a critical care group and they're a little bit more thoughtful before changing their vent settings or something. I don't know. It's like, usually we're a little bit further along. Okay, we're gonna stop at like 33% voted, 34% voted. Okay, let's stop there. And it is absolutely fascinating to see ventilation support still be like such a huge challenge. I mean, we've done quite a winding way of getting, you know, we were doing early intubation, then we were doing CPAP, BiPAP, and proning and et cetera, but still a big challenge for people. Okay, let's do the next one. Thanks. Cytokine storm really hit there too. All right, again, September 2020. Which of the following is the biggest problem our organization has in managing critically ill COVID-19 patients? And the list is not exhaustive, but hits some high points that we've heard and talked about on rounds before, that's for sure. Okay, so I see the comment missing, I'm not a critical care provider. Yeah, I missed it, so that's why. All right. Well, you know, no, just in my own defense here, like, so, you know, EMS actually sees critically ill COVID patients, so you get a shot too, and emergency department too, so yeah. Now, go into that in much more depth, but I think I'll pass. We got 35% of you voted. All right, just about 5 more seconds. All right, let's stop there. Clearly, adequate numbers of trained staff was the front runner. And let's see what adequate numbers of staffed beds, which obviously is connected up with staffing too. And then adequate PPE, still a problem. It was interesting, yesterday we saw a turn for the first time in the PPE responses. For a while, it was gowns being the shortest. In the EMS rounds we did yesterday, it was N95. So a little bit of a change there. All right, next, thank you. To support mental health of our staff, our organization, and this is not just like exclusively for critical care, so you could all respond to this one. All right, 5 more seconds, echo, and then we'll stop. 46% voted on this one. 48%, man, it'd be great to get 50. Yeah, there we go. Great, 50%, perfect. Wonderful, let's see these. 22%, well, 24% don't know, 22% each for using a non-buddy system, and 22% said no organizational support for mental health of staff, 18% formally using a buddy system. All right, thank you. Next. I think maybe one more, or is that it? Oh, yeah, there's two more. Our organization has cared for critically ill grade school age COVID-19 patients. All right. There we go. Let's stop there. 50% of you voted. 16% said yes, 60% said no, and 24% said don't know. All right, next and last one. Everybody focus, get away from your email, get focused so we can get this last one done. Our organization has cared for critically ill college-age COVID-19 patients. And then for those panelists that have been able to remain on, your last comment or question, and then Amy and Jen, I promise you get the last word. But I'm gonna have one really quick question for each of you though. %46% have voted. Also, we do not do individual identifiers, as in when you respond, we don't know or use who you are in your responses. I should have said that off the top. All right, let's stop there. 51, it was like our highest percent responses. This one's fascinating to me. I mean, I had no idea how this was gonna roll, but 30% said yes, 44 no, and 26% don't know. To me, I just had no anticipation it was going to be that high in terms of the 30% responding yes. All right, thank you very much. Really appreciate your responses as always. And let's see, back to the panel. Carol, any final comments, questions?
No, just thanks for a great presentation. That last question, it'll be interesting to see if those statistics change in large university cities as schools reopen. But I love hearing it from people who are actually doing the job. Keep up the good work. Thank you.
Ditto on that. Bruce.
Again, an excellent presentation and another reminder that it really does take a village to get these critically ill patients well. So hats off to our nursing colleagues, our PT, respiratory therapy, and everyone else in the industry who really has stepped up to get these patients better. Thank you again.
Thanks very much, Bruce. Well, gosh, there's one more question. It's like, hang on. Here's a question. Do we have any catalog or cooperative around university systems across the country to collect data of how many COVID patients have been treated utilizing ECMO, deaths, discharge with or without deficits, et cetera? I have no idea. If somebody has an idea, put it in the chat, but I certainly have not seen it. We have had, I can tell you, we have had dialogue at HHS with the American College Health Association, and actually had 2 collegiate EMS systems yesterday, one from Rice University and one from MIT, speak on the rounds, and hoping to get some others talking about some of the college challenges as well. So a question for Andrew and Jen. I know we're like at 104, but a specific question that I want to make sure you get a chance to. So, okay, mental health, fatigue, complacency, those 3 phrases, words, have been persistent, consistent, and with increasing, seemingly increasing challenges. And it strikes me in just listening to you, you don't, and if maybe you're just hiding it like greatly behind the masks, but you do not appear to be fatigued or complacent. So for each of you, would be helpful to give your like tip, or if you are fatigued and complacent, just say so. But you know, true confessions. But I mean, what is it that's keeping you like going? Andrew and then Jen.
I think for me personally, one of the big things, especially at work and working in biocontainment first and then transitioning to our more open COVID ICUs and things like that, it was really the we're all in this together thing. And it was working with my peers, you know, such as Jen, and just being able to like develop that close relationship and understanding how we all work well together and things like that really made it survivable. Like we all know we couldn't have made it through, especially with some of these staffing ratios and ever changing guidelines and things like that. We really needed to like lean on each other and our coworkers and kind of become a family up there and learn how to work together every day. And I guess just for me at home, it's just remembering like all the little things that we do for ourselves, like taking time to like read a book or just go sit outside for a while and just focusing on the things that make you happy outside of work and to decompress from all the stresses and take a break from what's going on in the outside world. So
Doctor, I was going to say lots of coffee and under eye concealer is really the secret, I think. But no, but on a more serious note, I'd like to just reflect what Andrew said. I think that it's really important that we lean on each other, and not just as nursing colleagues. Not only does it take a village to bring a critically ill patient from the brink of death to walking out of the hospital, it takes a village to support each other. I know that some of my physician colleagues that I'm a little bit closer with would come and check in on me, or we would check in on each other like, hey, are you doing okay? I know today was really hard, or we did some really hard or sad stuff today. Are you doing okay? And just having that accountability to check in with each other and allowing yourself time to be fatigued, that it's okay to be tired, it's okay to be frustrated, it's okay to feel all of the feelings that come along with this absolutely unprecedented event, that we are still human, and to be able to function still at a level where we can provide that care for patients, we need to allow ourselves the space to have a day to be upset or have a day to feel your feelings, kind of thing. So
Hey, thanks both of you for your observations on that. We need to, I mean, we as healthcare professionals really need to like address this head on, and I appreciate your sharing your personal observations on it. So Andrew and Jen, you get the last word. Any questions, comments that you might have for the entire group before we end?
I guess first off, Dr. Hunt, for me and Jen, I think both of us, we can't tell you how much we appreciate this experience and being able to be here to present to you guys today and getting a chance to just kind of have the roundtable discussion we did. And I know it was a really great experience for both Jen and I to be able to go through and like kind of relive this patient experience and to like look at it from a, 2020 hindsight kind of thing, for lack of a better term. And it was just a really good experience to see where we've grown and come. And sometimes you don't realize the small changes we make in our policy, procedure, and the way we practice. And it was really cool to just see how we've grown and how we've changed and thing as a hospital and staff in general. So.
Yeah, we got to speak with a lot of our nursing colleagues that help with the care of this patient to remind us of some of the challenges that we faced. And again, I just wanted to thank Dr. Hunt and Project ECHO and all of you wonderful people that have spent so much time making sure that we are safe during this pandemic, and our staff is safe and our patients are safe, and we were able to move forward stronger together. It really does take a village. I think that is my closing remark. This takes a village of everyone to work together to get ourselves through it, get our patients through it, and come out the other side stronger.
Thanks, and it kind of inspires me to keep the village going for at least
And we thank you for that.
So no, very much appreciate that. To our participants, you've been like great, just the chat and the questions and answers, and yeah, I'm always frustrated. I can't get to all the questions, but I also know people have things at 1 o'clock and they got to get off and so forth, so on. So to our panelists, Bruce, Carol, thanks very much for being here. And I also want to make sure that people are aware that we need to think about our colleagues at the bedside taking care of patients with us, and also maybe double down a bit for those who are doing double disasters with wildfires and hurricanes and COVID. We've had rounds on each of those before, and sadly we might have to have some more in the future. But hard times for sure, hard times. And Andrew and Jen, yeah, we need to take some of that and lack of fatigue and complacency and bottle that and share that around. Appreciate your contributions. Bruce and Echo, thanks very much. See you all on the next one. Bye.